Welcome back to the course in Nuclear Medicine Physics. Today we'll be looking at radiopharmaceutical therapy. Now, the main idea behind this kind of therapy is that you use radiation to help treat patients with various diseases. Usually it's cancer. The idea is that you inject a patient with a substance that travels to the sites of where the disease or where the cancer is, and it delivers the radiation in that region. What you really don't want is you don't want leakage to other regions, and so we'll look at a variety of factors that allows one to decide what the best type of radiopharmaceutical is for a specific task. If you enjoy this series, please remember to like and subscribe, and enjoy the video.
Nuclear medicine covers both diagnosis and treatment. We've said this before. So this aspect of radiopharmaceuticals used for therapy, is increasingly being called radiopharmaceutical therapy, but it has been known and it continues to be called with many different names, and that might create some confusion, but these are all the same. So radionuclide therapy or targeted radionuclide therapy, radioligand therapy is another name that is being used, for example, at least for a subset of these methods. Molecular radiotherapy, I like this name because it kind of emphasizes that radiotherapy is not just external beam radiotherapy. You also can do internal through a molecular mechanism. It's a very exciting name, I find. And also molecular targeted radiopharmaceutical therapy. And so the idea is you have an agent, which could be like a large molecule, like an antibody, or it could be like a small molecule, like a peptide. Or it could be even like microspheres that target and stay around a tumor. So again, if you have a molecule that targets something, a protein expressed by a tumor, and it just sticks to it and stays there for a substantial amount of time and bombards it with particles, then you could be killing, for example, those tumor cells in the case of treating cancer. It's not limited to cancer, but I'm just giving you an example. So again, you could have something like iodine-131, which, for example, can be used for thyroid cancer, or yttrium-90. Depends what it's labeling, but it could be used, for example, to treat neuroendocrine tumors, for example. It could be used to do liver cancer, which I will talk about in a second. So again, radiopharmaceutical therapy, the idea is that your body delivers it through the blood system circulation. Ultimately, it delivers it to wherever it finds and comes across, for example, tumors that are expressing a certain target that radiopharmaceutical is targeting. So it's kind of exciting because the cancer could be all over the body. You could have micrometastases that this could potentially treat. So again, this is in contrast to external beam radiotherapy, which is the common way of doing radiotherapy, where you go from outside and you illuminate from outside. Interestingly, there is a connection to external beam radiotherapy to nuclear medicine. Originally, nowadays for external beam radiotherapy, which uses X-rays through LINACs, linear accelerators, originally people were using so-called cobalt-60. So that's actually nuclear medicine, because cobalt-60 is this radioactive isotope, and even to this day, some centers continue to have cobalt-60 external beam radiotherapy. So these are hot sources, right, of cobalt-60 that, again, you use to target from outside. But the point is, these are coming from outside, and nowadays more and more they're using LINACs, linear accelerators, which produce X-rays, not gamma rays. But originally, there's a connection, interestingly, to nuclear medicine. But again, when we talk about radiopharmaceutical therapy, we're going from inside. So the ideal procedure here is to have highly specific agent concentrated in the target of interest. Ideally, you should do diagnosis by imaging beforehand. And then the agent delivers a therapy dose to target only with minimal effect on surrounding tissues. That's ideal. And target is destroyed and procedure is verified. So again, these are the two kind of approaches that are typically mentioned. However, nothing is perfect, right? So you could be exposing surrounding tissue, whether you do external beam, or, for example, if your radiopharmaceutical is taken up by by non-specifically by a target you do not want it to be taken up, but it does. For example, in the kidney, you may accumulate anyways. So then you sort of have to balance, because you don't want to inject too much, because then those normal tissues will be impacted, and you don't want to inject too little, because then you're not able to kill the tumors, for example. So why do we use radiation to treat cancer anyways? Doesn't radiation cause cancer? So this is something that often in the minds of people. And Carlos will talk about this, extensively in the context of the later chapters when he talks about, for example, chapter 17 of the text. So there are deterministic effects due to radiation. If radiation goes above a certain threshold, you're going to have deterministic effects. For example, you could have these kind of cataracts and infertility and things like that if you go above a certain threshold. Also, there's stochastic ones that there's no threshold. People think there is probably no threshold. There's some debate in the literature. But the idea is there is a chance, no matter how much you're injected, that you might develop cancer. So this is things like developing cancer or genetic damage, etc. So then why use radiation? Well, cancer cells tend to divide quickly and grow out of control. Radiation therapy kills cancer cells that are dividing, but it also affects dividing cells of normal tissues. So it could be damaging normal cells, causing unwanted side effects. So radiation therapy is always a balance between destroying the cancer cells, for example, and minimizing damage to the normal cells. So there is a risk of producing a second cancer. And it's always there. And it's an area of intense interest and study and focus and increasing public awareness. And in fact, a little bit of a too much worry sometimes. And often the time required for a carcinogenic effect to develop will be many years, and is very likely to exceed the patient's life expectancy, okay? So this is kind of a balancing act. So there's increasing awareness of this. And Carlos will talk about this. So there's a lot of interest in further lowering dose to patients. So we have a question. Are there some sort? Go ahead, Carlos.
We have 3 questions waiting there for us. So I'll read it.
Yeah. I think I answered the first one. I'll get to the second one. Just wait for me. I will get to these. And if I don't, please remind me at the end. So what are some of the factors which influence the target dose? In other words, you are injecting into the body, it's accumulating in different organs, but okay, so how much harm could it do, for example? Well, it kind of depends. And again, this is a field of dosimetry. Again, Carlos will talk about this later. I'm just preparing you for it. But it really depends where the isotope or the radiopharmaceutical localizes, what kind of emissions it gives. You could give alpha, beta, gamma, X-rays, and also Auger electrons. The half-life matters, metabolism, excretion. So this has to do with the biological half-life and things like that. So again, this dosimetry, which is a very important area and an area of intense interest in our own team, many others are focusing a lot on dosimetry. As you know, in external beam radiation therapy, this is done routinely, but in internal and radiopharmaceutical therapy, this is not done routinely. And this is something that many teams are trying to change, or a number of teams are trying to change. So it's really a question of how to balance amount of radiation to, for example, tumors versus normal tissue, especially like organs at risk. So again, you want to have treatment efficacy, so you cannot inject too low, but you do not want to have normal organ toxicity, so you don't want to inject too high. So you have to find this balance. And this is a field of dosimetry. Carlos will talk about it. This is going to answer one of the questions here. So actually, therefore, there's different kinds of radiation therapy. There is external beam radiation therapy. We talked about that. There's internal, but there's 2 kinds of internal. So one is internal with unsealed sources. So this is what we're talking about today, radiopharmaceutical therapy. You inject something, typically you inject it. You could also drink it, for example. But there is one with sealed sources, and this is what brachytherapy is. And we're not going to talk about that. So brachytherapy is where you have these sealed sources. And for example, this is an example in prostate cancer. So, when somebody has prostate cancer, there's different therapeutic pathways. Sometimes they take the entire prostate out, But sometimes they place these seeds, as they call them, in brachytherapy, and often this is done using the body cavity, so using the rectum transrectally with some ultrasound guidance. You would insert these, for example. Or you could, for example, use in different applications, for example, you might use surgery to insert and things like that. But the point is that these are sealed sources. They're not going to flow out of these, and they stay in the body. Typically, they, we're looking at months, for example, 10 months that this is going to be effective. And then you would, so we're not talking about brachytherapy today. We're talking about unsealed sources, internal radiation therapy, which we're calling radiopharmaceutical therapy. So let's talk about this a little bit more in detail. So I hope everybody's with me. There's so much material here and so much excitement, but just hang in there, okay? And I know many residents are listening, and I think this part is for some residents who are not nuclear medicine residents. I think this might sound quite interesting and magical, and it is magical. It's amazing. So overview of, we're going to overview essentially therapy with unsealed radionuclides. We're going to talk about some of the properties here, some radiation safety considerations we're going to talk about today. So let's do a true and false. Let me poll here. So the question is, a diagnostic radiopharmaceutical may be injected at, let's say, 10 millicuries. This is actually the case, for example, in FDG, to a patient. A therapeutic radiopharmaceutical may also be injected at nearly the same activity. Is this true or is this false? Think about it. Again, this is an anonymous poll. Feel free to give your answer. So diagnostically, we may inject a radiopharmaceutical, like FDG, we do at around 10 millicuries, which is 370 megabecquerels to a patient, give or take. Of course, you modify typically based on the weight of the patient, etc. But let's say around 10 millicuries. Does it make sense for a therapeutic radiopharmaceutical to be possibly injected at nearly the same radioactivity? So we've got about 3/4 of the people having answered. Okay, so let's see. Let's end the poll. Most people said false, but that's actually not correct. And you may be thinking, well, because intuitively, and this was a trick question, intuitively you're thinking, well, wait a minute, I want to give 10 millicuries diagnostically, and I told you before that it's, diagnostically you tend to have smaller, you don't want to harm, for example, any organs, whereas you're thinking intuitively that therapeutically we should be injecting more. But the answer is more of what? This is radioactivity. Please do remember that, for example, if the half-life of a radiopharmaceutical is long and it stays in the body, even though the activity may be 10 millicuries, but that radioactivity is there to stay for a very, very long time. So the accumulated radioactivity will be very large. Another way to think about it, so the answer is actually true. Another way to think about it is as follows. Let me do it like this. Remember last time we said that the carrier-free specific activity is sort of related to one, or this big number at the top divided by, it's proportional to 1 over the atomic or the molecular weight times the half-life, right? So, and remember the units here were, let me bring my cursor back here. The units were becquerels per gram. Okay, now invert that, so grams per becquerel. So you sort of see that the grams per becquerel is proportional to the half-life. So imagine you got 2 radiopharmaceuticals. Imagine them to have the same molecular weight, so A is the same. And imagine both of them to give the same effect on the body per disintegration, per individual radioactivity. The only difference between these 2 radiopharmaceuticals is the half-lives. But according to this equation, for the same becquerel, you're going to have more grams, more amount of that material for the longer half-life material. So there's more stuff, even though right now you're seeing the same amount of radioactivity for these two, but the total amount of material that will be decaying, if it all stays in, is going to be far more. So I hope that sort of explains that. So let me just, for example, show you examples of different radiopharmaceutical or radionuclides, for example, used in therapy. Look, a number of them, for example, are given. This is the dose there, or the injected activity, 10 millicurie. See, 10 millicurie. This one's even actually quite less than 10 millicurie. This one's only 6 times about 0.1. This one's definitely less than 10 millicurie. This one can be done at 10 millicurie. So you sort of see that actually that's not immediately obvious. And I hope that example kind of helps to understand the point. The point is, it's not just the radioactivity, like in becquerels, that matters, or millicuries that matters. It's the total accumulated time. So the half-life makes a big difference. So, and also just to give you some examples, here's an iodine 131, which could be taken for cancer of the thyroid, or it could be taken up for, other kinds of malignancies like hyperthyroidism. And again, these are taken, for example, orally, but often, radiopharmaceuticals are given intravenously. They're injected. There's many different, again, applications to radium-223. I think I remember one person mentioned this in one of our first lectures. Yeah, so this is given for bone metastases. Strontium-89. This is also looking at, bone metastases. And some of these are historical, some of them are more recent. And so, for example, you've got, samaritanum, you've got yttrium, lutetium, rhenium, different applications, different diseases that they're given for. So just show you some examples of radionuclides and their half-lives. These are physical half-lives, but because of biological half-life, the effective half-life will be less than these. But for example, yttrium-90 and lutetium-177 are two radiotracers that we're going to especially talk about today because there's so much exciting applications happening. But historically, iodine-131 has been at the frontier. So let's talk about this a little bit more. The basis of radionuclide therapy or radiopharmaceutical therapy is simply the placement of the radionuclide in intimate contact with the target. So if you've got short-range particle emitters, like alpha or beta, for example, particles, the absorbed dose to the target is going to be very high compared to non-target tissue. So the route of administration may pose different radiation safety issues. So oral versus intravenous administration, for example. Now, it's important to also note that radionuclides are given for curative intent, but they could also be given for palliative intent, palliative therapy. For example, in bone metastases to lower pain, for example. And most radionuclides in radiopharmaceutical therapy emit beta particles, but some also emit Auger electrons and alpha particles. And also some also at the same time inject gamma rays and X-rays. So this part can be used for imaging. Do we have any questions here yet? Yeah, so the question was, so there is no guarantee that a cancer patient will not suffer another cancer because of radiation. The point is about balancing risk versus benefit. So, for example, if the chance of inducing cancer in somebody's lifetime is far, 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 far smaller than the chance of this kind of imaging modality or therapeutic modality to actually treat cancer, help treat and manage the patient, then you sort of put these against each other. And I think Carlos will talk about this more. For example, in children, because their body is very sensitive to radiation, and also they have a longer life ahead of them, there's a lot of focus on lowering dose onto, for example, infants and children. So we'll talk about those later. There's the so-called different campaigns like Image Gently campaign, for example, for children and infants. We'll talk about that. A common metabolic radionuclide for thyroid therapy has been iodine-131. We'll talk about that a little bit here. So if you have a radionuclide that emits beta particles, for example, purely, or alpha particles purely, with nothing else, that's ideal in the sense of therapy. So, so radiation safety in that case will be primarily the safe handling of excreta and bodily fluids. So you're not worrying about gamma rays coming out of the body and impacting the person taking care of the patient, for example. In that sense, it's ideal. However, when radionuclides also emit things like gamma rays, for example, like iodine-131 does, or these things called Bremsstrahlung X-rays, we will talk about this for yttrium-90. It's an important thing for you guys to learn about Bremsstrahlung X-rays. Then there is a chance that they could be also exposing not only the patient, but also people right in their vicinity. But again, the calculations, first of all, you would be surprised by the numbers here, that these numbers are extremely safe in the amounts that are given. So even the patient is being treated from a occupational hazard perspective, or the people that are near to you, there's very, very careful and safe limits that are observed. So here's an example of samarium-153 that has been used, for example, to do bone metastases, to deal with bone metastases, okay? So just an example of an application for palliation of bone pain. It's not for curative purposes, but it's for palliation. There's this thing which, again, in the future we'll talk about, linear energy transfer, LET, very important topic that we will discuss in chapter 6. But essentially, it's basically how much energy you're depositing in your immediate vicinity. It's a derivative of energy deposited to distance. So it really indicates how much impact, how much lethality, in a sense, you're having. So if you're emitting alpha particles, because alpha particles are very heavy, they end up having a low range in the body. They're stopped quite sooner. They're very heavy. They're stopped sooner, and they end up depositing a lot of energy in a short distance. So that's why their LT is high. Beta particles, on the other hand, because they're much lighter, they end up penetrating more, they travel more, and therefore their LT is less. So they kind of go over a wider range. Auger electrons, and you've learned this in chapter 1, Auger electrons can also be used for therapy. There's a lot of, you could say, excitement or interest in studying them. The point is that they're emitted at very, very small initial energies, and they end up traveling very, very small amounts. Their initial energy, unlike these two, alpha and beta, tend to be very low. And so they end up actually traveling quite small distances, and their LT is kind of in between. But the point is that the range by which they travel is very, very, very small. So again, you've got different ranges of traveling. So you've got beta, which travels a lot, alpha, which travels less and departs a lot of energy locally, and Auger electrons that travel even less. So people are sort of saying, beta particles have been used for therapy, but alpha might be more successful in doing double DNA breaks. Auger electrons travel even far less, so you actually sort of have to make sure they get inside the membrane and also go inside the nucleus of the cells, and then there they can maybe damage the DNA. So it's not very straightforward how, you've got to design something that penetrates the cells, goes all the way in, and then it does harm and damage to the DNAs. So this is an area of very active interest. Beta is more popular, as you're saying. Alpha, a lot of excitement, and this Auger electrons, people are looking into it more and more. So again, and also, so beta sort of tends to travel at longer distances. But even beta, we have beta and we have beta. So for example, lutetium-177, the kind of ranges of energies of beta particles that it emits tends to be smaller. I think there might be a mistake here. Yeah, no, that's correct. That's correct. Tends to be smaller than for yttrium-90. Therefore, the range, the penetration here is 2 millimeters, whereas here is 1 centimeter, so about 12 millimeters. So you can sort of say that yttrium-90 actually penetrates more because the energies of beta particles that are emitted tend to be higher. So also, people have talked about, combining tandem therapy, maybe putting both of these, like you have a radiopharmaceutical labeled with this, and it's like a cocktail, and then you do it with the Yttrium-90 also. So this would sort of be looking at shorter ranges, and the other one for higher ranges.